So this is going to be a quick whistle-stop tour through of a few bits and pieces. It's really a taster. The people have written multiple book volumes on foot and ankle surgery and what you can do. So it's really a whistle-stop tour through of what can, as a surgeon, we do for patients. So I'm going to go through a few things, start with the forefoot, move to the midfoot, hindfoot, talk about a few things. I'm not really going to talk about tumours or infection. They're red flags. If you think those, they'll be coming up to our service fairly quickly anyway. I'm not going to talk about diabetes. That's an entire conference in its own. And at the moment, we're not involved in the diabetic foot service. That's the diabetologists and the vascular surgeons currently, and podiatrists. That will probably change in the next 2 years because I think it's a service that needs a revamp. And we're currently having meetings about orthopaedics being involved in that. But at the moment, we only get involved in the osteomyelitis patients and a bit of Charcot. So things you're going to likely to see in primary care and in physio. Big toe arthritis would be the first one. It's relatively easy to diagnose. They usually have a stiff, painful big toe. They have a bump. Normal range of movement is about 40 degrees to 40 degrees. You need 90 degrees if you're running. The usual first complaint is it hurts when they walk, and that's because the toe's stiff. It doesn't come up beyond about 20, 30 degrees, and that's because the base of the proximal phalanx is impinging on the metatarsal head. So that's the first symptom they usually complain about. And then it progresses on to generalised pain, deformity, a large dorsal osteophyte, etc. So we've talked about all of those. It's dorsiflexion they lose usually. Plantar flexion is usually the last thing that goes. And actually, as the toe stiffens, what happens is it usually comes up less and less and ends up plantar flexed. So they can still plantar flex it, they just can't dorsiflex it. The grind test, if you want to inflict pain on your patient, by all means do the grind test, but it's going to be stiff, painful anyway. It's probably an old-fashioned test you don't really need to do, to be brutally honest. Very easy to diagnose on an x-ray. Treatment, again, surgical, non-surgical, and it's about managing symptoms, really. At the end of the day, can they manage their symptoms? If they can, there's quite a few things you can do that are non-surgical. When they can't manage the symptoms, it's interfering with either footwear or what they do for daily activities, or pain RS, pain at night, then refer them in and we'll see them. So there's lots of things you can do. Stiff-soled shoes, weight loss is always a good one. Sometimes it's just a question of getting the correct size shoes, because sometimes they're wearing shoes that are too small. Early stages, not too much deformity, mild symptoms. Injections is one of probably the three or maybe four things that we'll talk about in the second slideshow, just on injections. I'll go through it in more detail, but it's just to remember that it's a ball and socket. So you don't stick your needle in. You've got to come in at about 45 degrees and 45 degrees. So actually you're trying to get in underneath the base of the proximal phalanx, so it doesn't quite show it there, but that's coming at an angle. It's not going straight in like that, like it appears to be on the screen there. So yeah, so you just go in medial to extend to hallucis longus tendon. There's nothing really. As long as you go just medial to tendon, you're fine. If you go too far around the corner, you might stick it through the dorsal digital nerve, which is not a good idea. Surgically, two real operations, I suppose, for hallux rigidus. If it's just painful when they walk, they don't get rest pain, they don't get night pain, then a chylectomy is a good operation. All you are doing is just removing the dorsal osteophyte, as you see on the screen there. So you take that off, and all you're doing is increasing the range of movement. Okay, gives patients usually between, it says 92% of 9 years there. I would say between 2 and 5 years is what I tell my patients. It doesn't stop the progression of the osteoarthritis. Excuse me. It doesn't make the condition any easier. It just stops that block to movement. Once it's progressed and you get into a stage, you've got rest pain, night pain, big osteophyte, deformity, all of these other things, then you're really looking at some sort of surgery on the MTPJ. It sort of depends on what you're trying to achieve. So you can either fuse it or you can replace it. Fusion was always described as a gold standard. Patients do very well as long as it's in the appropriate position. I've seen patients run marathons on fused toes. You can get away very well with them. The slight downside is that occasionally you get transfer metatarsalgia. You can get arthritis in the IPJ, TMTJs. Sometimes they've actually got osteoarthritis of the sesamoid joints, those two little joints you can see. Wrong one. Just here. So that in itself can sort of limit movement rather than anything else. So you can fuse it or you can replace it. The advantage of replacements is that you usually don't develop arthritis of these joints because you've got some movement. Most ladies over the age of 60 like it because they can still get some sort of heel on and they can still get their appropriate footwear on. It's never brilliant. They still have it. They get rid of the arthritic pain, but I think most of them still have a stiffness and a bit of a stiff ache in the toe, and that's what I tell the patients. Most of the patients I see back at 3 or 4 years for other problems have done their exercises really well for 6 months, and then they stop doing them, and over the last 3 years, the toes are slowly stiffened up. The only nice thing that happens is that when it stiffens in the position that you would fuse it in. So rather than it being plantar flexed, it will actually stiffen the position of function. So even if it goes stiff, they actually have a really good function. And I think it, because I do some hips and some knees still, and if you notice as you go down the body, the joints get more painful, they get less stiff, they get less decent function. So hips do really well, knees almost as good as hips, ankles not bad, and toes sort of. But you have options, and occasionally I will put a toe replacement in labourers who are having to wear steel toe cap boots because it's quite difficult getting those on when your toes stiff. You just can't get your foot around the corner, particularly some work boots. So as long as the patient understands it's still going to be stiff, it still might ache because they've got stiffness and it's a stiff ache. And you can't do it if they've got arthritis in the sesamoids because they're still going to get the stiffness, so there's no point in doing it. Hallux valgus is the other thing you're going to see in primary care and in physio in various places. Can occasionally get confused with hallux rigidus. People see a bump and say, oh, it's hallux valgus, and I think the important bit is the movements in this should be normal. In a slightly different plane from normal, but the movements are normal. With hallux rigidus, can look the same, but they're stiff. Caused by shoes, I think the jury's out about that. There's certainly some familial tendency in genetics. You certainly see hallux valgus in communities that don't wear shoes. So some of the indigenous peoples in Africa and South America, they've noticed that people get hallux valgus. So it's not all to do with footwear. Some of it's to do with position of the foot. Can be other things. It's quite common with things like rheumatoid arthritis, inflammatory arthropathies, because they get a soft tissue problem and the toe just drifts off. Again, you can try things that don't involve surgery. I think for me, hallux valgus, you can maintain the symptoms, you can control symptoms without surgery. You're not going to cure the problem. And the problem, if you go look at that one, is the bowstringing that patients get. So once the toe starts to drift, you've got the hallux valgus pulling down here, you've got the extensor hallucis longus and the flexor hallucis longus and the lumbricals. They're all pulling here, so it acts like a bow. They will tighten and that will go that way. So you can control it with splints, you control it with movements. And a lot of patients who are comfortable and don't have any pain don't need surgery. I'd love to see somebody walking with those bits in the middle though. That'll be a fun one, particularly with a pair of shoes on. So if it's painful or it's causing other problems, and I occasionally see patients referred with a second mallet toe, and the patients look a bit shocked when they say, well, first I'm going to do is straighten your big toe out because your big toe's knocking your second toe up. So it can cause other problems. You can get transfer metatarsalgia because you actually start to offload the big toe, so all your pressures are going on the third and fourth metatarsal heads. So sometimes the problem is the big toe, but actually the symptoms are elsewhere. And you're correcting both the hallux, both the metatarsal, but sometimes you've got to correct the toe as well. So sometimes they've actually got a deformity here as well as here. So you sometimes end up doing 2 operations, one here and one there, just to correct the toe and make it straight. So good example is there. where they've got hallux valgus. They've had a scarf osteotomy, which is described here, but they've also needed an osteotomy here, which you can see there. Take a little wedge out and just straighten the toe. So instead of it pointing in that direction, it points in that direction. And it's one of those things, you do one, if they need the other one, you do the other one. Not everybody needs it, but quite a lot of people do. What else can cause pain in the forefoot? We can get mallet hammer toes, you can get transfer metatarsalgia if the second and third metatarsals are so long. So this patient here, particularly if they had a hallux valgus, would probably have pain here, because if they're defunctioning that's where all your pressure goes. So about half your pressure should go through here. If the pressure starts moving around this way, they're going to get pain. You can get a bunion on the fifth toe, which you can see there. You can correct that very easily. This is one of my patients, and you can straighten everything. She wasn't rheumatoid, although it looks like a rheumatoid foot. She did very well. Sometimes you end up just taking the second toe off. If that's the only problem, everything else is fine. They're not particularly mobile. It's simple. You can do it under local. So the surgery is what the patient needs, not what you want to do to them. Moving up to the midfoot, so that's really sort of from the TMTJs here up to the talonavicular joint, really. You get arthritis, so you get bulges in the middle of the foot like that. You probably get an x-ray, something like this. We might get arthritis in there. Occasionally it's due to a Lisfranc injury, so you can sometimes get injuries to the ligaments around here. I think the reason they get arthritis in this bit specifically is you've got to remember the foot is two arches. So you get an arch from the toes to the heel, and you also get an arch from the lateral border of the foot to the medial border of the foot. Where those two arches meet is the base of the second toe. So think of it like the keystone in two bridges. It's held together with lots of ligaments. If they become wobbly, so if there's arthritis in here, they become slack, or if they've had damage, or if they've got rheumatoid or something, you'll start developing instability here and they get arthritis. That's usually the main cause of sort of midfoot arthritis, if you like. And there's lots of surgeries you can do, up until including something like this lady here who had sort of quite significant flat foot with arthritis here, but also collapse and actually arthritis there. And the idea of surgery is to try and restore the foot. Now, I think this is a bit of symptomatic because they haven't really restored the arch there. If you actually look at that, there's still a break in the foot. So there's lots of nice complicated surgery. The point of surgery is to restore the shape of the foot. If a foot looks normal, it's probably going to function normally. If it's flat and deformed, it's not. So a foot that's foot-shaped and stiff will function better than a foot that's not foot-shaped and painful because of the forces going through it. So although we're stiffening joints and getting rid of some function, technically, most of the time the function's not there to start with because it's arthritic or it's deformed, and you're giving them a stable platform to walk on. And that's the whole purpose of the surgery. You make the foot look normal, it will function normally, and that's what we're trying to do. Little bit more about flat feet. Again, flat feet is something you may come across quite often in general practice and primary care and in physio. I think the point is if it's painless flat foot, it doesn't need anything done normally. It's only when it becomes painful. Can be acquired. It can be, you see adults in the 20s and 30s. Quite often you'll see it in little old ladies that suddenly develop a flat foot, and that's usually because their tibialis posterior has given way. So acquired flat foot is something that you maybe need to look into more appropriately. And the problem with acquired flat foot is it will become painful, they will defunction, they won't be able to walk properly. Catch it early, you can sometimes repair the tibialis posterior, support it. If not, you're looking at fusions, again, to recreate the arch, recreate the foot, and give them a stable platform to walk on. Because with a tibialis posterior that goes, what happens is the foot collapses, the arch collapses, the foot externally rotates, and they've got no power to walk off. Everything just gives. Yeah, and you can usually tell it from the side. Sometimes the flat foot, when you see them, you look at them from the back, you find the too many toe signs, the foot's externally rotated. Treatments, non-operative and operative, insoles. Sometimes if it's acute tibialis posterior problems, resting them in an air cast boot for 6 weeks and then physiotherapy is all they need. Sometimes they need debridement of the tendon, reconstruction of the tendon, or you might even go to reconstruction if it's flexible. And if they've got a tendon that's completely gone and they're starting to develop arthritis, then you're looking at fusions again to recreate the arch, recreate the arches that they can walk on. The other thing you'll probably come across, particularly in physio, would be ankle sprains. The ones I operate on are the ones that are chronic. So most ankle sprains settle down. The bad news for patients, it takes a minimum of 3 months for a sprained ankle to settle down and probably 6 months for that ligament to heal. There's plenty of professional footballers who do their ankles, they're off for 8 or 9 weeks, and when they go back to football, having had physio 6 days a week, you don't see all the strapping that goes on underneath their football socks to allow them to play again. It's usually the ATFL. I think I've got another slide of it there. Yeah, so it's usually this ligament that goes, sometimes that one. Very rarely does it actually snap completely. It often is torn and damaged. With appropriate physiotherapy and sprintage and strapping at the beginning, most of them settle down. The ones I operate at 2 years have healed, but they've healed stretched, so they have an instability. So practically everybody I scan, the scan report comes back and says, oh, ATFL's intact. It's not functional, it's stretched. So when you're examining these, and I'll go through that later on with examining, what you're looking for is you put a finger on or thumb on the fibula, you put one on the talar head, and you can feel that in the foot quite easily on the medial side. And then what you're looking at is how far do your fingers come apart before it stops. And you're looking for 2 things. You're comparing the sides. So does one side move more than the other side? And is there a firm end point? Because ligaments are a check rein. That they stop movement. They work, and suddenly they stop movement. If there's no sudden end point, it just seems to drift off into the distance, it's probably not functional, even if it's not torn. So most of the ones I see, you can do the anterior draw test with the other test that's described, where you hold onto the ankle and try and draw the foot forwards. And again, it's trying to replicate the same thing. It's a check rein, it shouldn't draw forwards, particularly if it does come forward more than the other side, then it's probably damaged. And I think the important bit is compare it to the other side. Patients will usually have a normal side for that patient. Even if they're, young, hyperlax, they will still have a normal side on the other side. Excuse me. If it doesn't, and they need surgery, there's 2 ways of doing it. You can stick a camera in and do it that way, or you can do the good old-fashioned Boston and Gould repair, which you saw on the previous slide, which is basically you repair the ligament, you double breast the ligament, and then you take the fascia off here and you triple breast it over the top. It still takes 3 months. There are accelerated rehabilitation programs. I know some of my colleagues do it. My personal preference, they go to plaster for 6 weeks, non-weight bearing, then they weight bear in a boot for 6 weeks. Whatever you do, it's going to take 6 months to heal, and you could augment it and do various other complicated stuff if you really want to. So that's the anterior draw test. As I say, you're just drawing the ankle forwards, and the important bit, and I will keep re-emphasising this, compare it to the other side, the uninjured side. Yes, occasionally patients have got injured sides on both sides, but it's unusual. Ankle arthritis. Don't see as much of this as we do hip and knee arthritis. You will see a significant amount of ankle arthritis. Most of it is post-traumatic. Occasionally it's inflammatory arthropathy, although that's quite uncommon nowadays. So most people 5, 10, 15, 20 years ago had some form of ankle injury. Again, the treatment is symptomatic, as with everything. So the first things are simple things: analgesia, modification of weight, all the other things you would do, footwear, supportive footwear, boots that lace up above the ankle, etc., physiotherapy to try and build the strength up around the ankle. When it becomes not treatable, And you can use injections. It's one of the other things you can inject in early arthritis. It's an easy injection to do, and I'll go through it in the other talk. If it's bad enough, then they might come to surgery. And there's other things. That X-ray on the bottom there shows AVN. So you've got collapse of the lack of blood supply here, collapse, and that's a normal bone, and that's completely abnormal. So you've got no blood supply in there at all. So as I said, analgesia injections. Injections easy. That's on the lateral side. I'd recommend, I'll go through it with you, but on the medial side, if you just go medial to tibialis anterior, and between that and the medial malleolus, there's a nice hole that you can always put your finger in, and that's where you inject. The neurovascular bundle is going to be sitting under the extensor digitorum longus tendon. So if you go the other side of tibialis anterior, you might stick it through an artery. To try not to. Again, remember that it's a dome-shaped joint, so you've got to come just slightly inferior to where you think you're going to be and aim up, about 30 degrees. If you go straight in, you're just going to hit the talus. You want to try and get between the talus and the tibia. And I'll show that on some of the other x-rays I've got in a minute. So yeah, so that's the injection technique, and it's just in this corner here. What else can we do with them? Well, we can stick cameras in them. Do it in knees, why not in ankles? It's just as easy. Sometimes patients have loose bodies, sometimes they've got big lumps in there. If their pain is just when they're walking, so they've got a big anterior osteophyte, but actually they don't get rest pain, don't get night pain. It's like doing a cheilectomy or subacromial decompression. You shave off the front of the ankle, gives them a bit more movement, usually improves their symptoms for a few years. Occasionally they're walking on it better, so the ankle gets worse because actually they're now using it properly. What do you see when you're in there? Well, lots of things you can see. You can see it's a loose body down the bottom here. That's this big anterior osteophyte, so actually the edge of the tibia is here. And what you do, you get a burn, you just shave that off, and it is just like doing a subacromial decompression in shoulders. So that's a probe in the ankle joint, so you get lots of loose cartilage. That's sort of the view you see. Other things you can see, that's an area of bare bone. That's an osteochondral defect. So the cartilage is broken, and you can see putting the probe in, the cartilage is all loose on that. And the treatment for that is you take away the loose cartilage, and then you sort of make little holes in. It's called microfracturing. And what you're trying to do is allow it to scar up with hyaline cartilage. So it's a different sort of cartilage from the normal articular cartilage. Works quite well. Used to do it in knees as well to a degree. I think they're moving away from that now in knees, but in ankles it seems to be still the best thing to do for them. Once they get to the stage where they're getting pain all the time, limiting their walking, stopping what they're doing. Oh, sorry, I forgot to say, you can also go in the back of the ankle. So this is the back of the ankle. That's the Achilles tendon. That's a camera. What do you see at the back? Well, that's what you see at the back. You can take off these nice, so they've got posterior impingement. You can take that off, so you can shave that off. That's your flexor hallucis longus. That's your heel bone, calcaneum. Your tibia's up there, and this is the back of the talus. So you get a nice view of the back of the ankle with the camera. And again, there's lots of conditions you can go in through the back and do. When you get to the stage when you can't control the symptoms, they're suffering, they need something else done, they've got night pain, they've got rest pain, you're really looking at two options. You're either looking at a fusion or a replacement. Fusions, if there's deformity, probably a fusion. I think it used to be described as a gold standard, an ankle fusion. They got rid of the pain, they got walking again. That said, you've got to be very precise in where you fuse it. The position of the foot. It's got to be plantar grade, 5 degrees of valgus and 10 degrees of external rotation. Now, if you can do that clinically every time you do one, I think you're doing pretty well, because you know, 5 degrees is that. It's not a lot. You get the position wrong, you can cause pain under the lateral border of the foot, medial border of the foot, the heel. They might not get the heel down flat when they're walking. So it's quite a precise operation, actually, although it sounds very simple. There are numerous ways of doing it. Most of them are done arthroscopically, and then you stick 2 screws across, as you can see here. If there's a lot of deformity, you sometimes go in through the side, take the fibula off and use that as a graft to put back down. Or the alternative is to replace them. We do, well, I think we did 16 ankle replacements here last year, and we've got 10 on the list so far this year. We're changing how we think about ankle replacements, certainly the last 5 years. So 5 years ago, there's patients that I would quite happily fuse. So most men, women under 60, I would probably have fused 5 years ago. little old ladies who are low demand with an ankle replacement. I think now I would say, why can't I put an ankle replacement in? So I'd be quite happy putting an ankle replacement in a 55-year-old builder, because I think they would do as well as an ankle fusion. Yes, it depends on their weight. Yes, it depends on what they do. And yes, it depends on their expectations. But actually, some people in manual jobs need to have some flexibility in their ankle that they don't get with a fusion. The other thing about replacement is that with a fusion, you're going to quite often start over 10 to 20 years get arthritis in the other joints around the ankle, because they're taking the stress of the ankle that's now fused. And particularly those patients that already have subtalar arthritis or talonavicular arthritis, you know they're going to come to a fusion, and therefore you want to try and maintain at least some movement in their ankle. So my personal view now, and I think it's being shared by most foot and ankle surgeons, is why can't I do an ankle replacement? Yes, sometimes it's very deformed, and yes, sometimes they're 55, they're 6'4", and they stomp around, and therefore that's probably still more suitable for an ankle fusion than a replacement, because you've got to remember that an ankle replacement is probably the same size as the silver end on here. So it's about a quarter of the surface area that you're walking on from a knee replacement, a third to a quarter. So the other thing is, how far can you push it? And this is the other thing that's happened in the last 5 years. How far can you push it? Well, that looks fairly nasty and arthritic. I would call that a fairly easy ankle replacement to do. So that's what he had. What about metal work? So you've got lots of metal work in there. Does that stop you putting an ankle replacement in? No, it doesn't. Thought I might have to take the pins out. Well, we didn't. Those pins were put in these pins were put in prophylactically because she had quite soft bone. But you can see you can slide an ankle replacement quite easily and didn't have to take any of that metal work out. So she'd already had a triple fusion. If you then fused her ankle, all she'd have would be a peg to stomp around on. Whereas with this, she's actually got a little bit more movement. She's got a much better walking pattern, a much better gait. And she's quite elderly, and therefore the work of walking is a lot less with an ankle replacement than it would be having a fused leg and stomping around on it. So how far can you push it? So that is a lady with fibular hemimelia, whose only movement was in the ankle. Everything else is stiff. I don't know if you can see that, but she's got cement there. So she's had 2 total knees and a total hip. Came back, ankle arthritis. We injected the ankle, took away all the symptoms for a month. So the only movement she's got is in this deformed foot. What do? Stick an ankle replacement in it. Corrected her foot by shortening her fibula a little bit. She's only 2 weeks down the line, but she's really comfortable, really happy with the position of it. So we'll see how she gets on. 5 years ago, you wouldn't even have thought of doing that. It would have been, oh no, you need to fuse that, love. You know, you're going to lose your leg. So things are moving on and things are changing. If they all go and you can't put an ankle replacement in, there's other things you can do. So you can stiffen the whole of the leg like that. At least they get pain. And the idea is you're treating the symptoms, you're trying to create something that somebody can walk around on. It's about mobility and about treating symptoms. The patient get what they need. One of the other things you're going to see a lot is Achilles tendonitis and plantar fasciitis and all these other things that you see. I think the point is that Achilles tendonitis, heel pain and plantar fasciitis are probably one and the same thing. So if you think of the band of tissue that comes down with the Achilles tendon, it goes around the heel and across the plantar fascia. It's continuous. If you look at a dissection, it's continuous. The symptoms are the same, the site is different. I think that's it. And the treatment is exactly the same with all of these. It's physiotherapy. They sometimes need heel cups to straighten if the heel's in varus or valgus to correct the heel. Occasionally they need a bit of a medial arch support if that's collapsing. Stretching exercises is the fundamental treatment for all of these patients. The more they can do it, the better. The number of patients I see in the clinic say, oh, I do it once or twice a day. And you tell them, go away and do it 4 times a day. Well, I can't manage that. 4 times a day is with meals and before bed. If you watch Coronation Street, that's 5 times a day. It's actually not difficult. If they can't do it 4 times, if they can't do it more than once a day, then they're lazy, actually, and they will continue to have their symptoms. Sometimes if it's very acute and very bad, and particularly those patients that get pain first thing in the morning, because people forget that when you sleep with your foot in that position. And it hurts really badly in the morning because the first thing you're doing is spending 20 minutes getting your foot to 90 degrees. And basically what you're doing is stretching your calf muscles and all your hamstrings. So I will sometimes put patients in an air cast boot overnight, give them a night splint. It keeps the foot at 90 degrees and makes it less painful in the morning as they get going. That often works. Sometimes I'll do that just to rest the tendon and just get rid of any symptoms and slow them down so they're not walking, and then they go for the stretching, etc. I have probably debrided 3 of these in my entire consultant career for simple Achilles tendonitis. 2 of those were Mr. Giles's patients. So actually of my own patients, probably just 1. I don't think there's any evidence, so that's what we just talked about. I don't think there's any evidence that makes a lot of difference. So no reliable evidence that injection PPE or stem cells or any of these other things around it, needling these tendons, people swear by them. If you look at the randomized controlled trials, they don't make a lot of difference. One of the few conditions that I might consider surgery quite early would be the calcific tendonitis that you see. So you see some patients have lots of blobs of calcium within the tendon. If that doesn't settle fairly quickly with physio, I don't think it's going to. And I think you have to remove those, repair the tendon, and then they usually settle down very quickly with physio and orthotics and the rest of it. Insertional tendonitis often is due to the same causes. Occasionally it's due to a Hagland, which is a large bump at the back of the heel, which is rubbing on the tendon. Now, in fairness, they've always had that. Sometimes they've done something too silly and it started to irritate. So sometimes you need to take the Hagland off or debride the tendon. And you really have 2 options. I mean, there is an option where you take the bump off, take the tendon off, put it back down, or you can actually just take a chunk of bone out of the calcaneum and close the calcaneum down like that. What you're doing is detensioning the Achilles tendon. That again seems to work very, very well. And you don't need to take the tendon off, because taking the tendon off, there's a much higher risk of wound problems at the back of the ankle. There's a risk that the tendon doesn't heal down or it rips off again. Whereas to do a calcaneal osteotomy, you're doing a little wound in the side here, and you can actually do it micro-invasive if you want, just with a small hole and a burr. Some people do that. I don't, because it's a 3 centimetre wound, but it's a much cleaner wound. It's going to heal much better. So you've got various options you can do with those, but the initial treatment is exactly the same. It's stretching. And it's stretching your hamstrings as well as your calf muscles. Now, a lot of people forget that the gastroc is attached above the knee. The hamstrings are stretched below the knee. So they sit like this and they interfere with each other. And I see a lot of patients who, intractable Achilles tendonitis or heel pain, their calf muscles are really stretched out. They've got really good dorsiflexion, they're really stretched out, and they ask them to stretch their hamstrings. They can just about get to sort of mid-thigh. You stretch the hamstrings out, the Achilles tendonitis goes away. So please get them to stretch your hamstrings as well as the calf. It's not just the calf muscles that's the problem. It's the leg. It's the whole leg. Any questions about that? So I think the first thing about this is about history. All right. I know probably everybody's banged on about it, but it is important. And even if you're referring the patient, it doesn't matter if you're referring for primary care to musculoskeletal or musculoskeletal orthotics into us. It's the history. You should be able to get your diagnosis from your history, and your clinical examination confirms your diagnosis for 92% of your patients. Okay. Yes, the age is important. Yes, your occupation is important. But what's the presenting complaint? What actually is the presenting complaint? If it's stiff, what's stiff? If it's painful, exactly where is it painful? You know, if you look at the lateral side of the ankle, for instance, you can get pain just anterior to the fibula, which could be tibiofibular ligament, but it also could be fibular-talar ligament, or it could be sinus tarsi syndrome, or it could be an osteochondral defect within the ankle joint. They will give you pain in the same place. You go 1 centimetre more medial to that, and it could be tendonitis in the extensor digitorum longus tendon or peroneus brevis tendons. So the exact site of pain is important because it will tell you where and what might be going on. Okay. Yes, a history of smoking alcohol is important, probably more for wound healing if you think of the surgery rather than anything else. Have they had trauma? Do they have neurological disturbance? You know, is it diabetes that nobody's picked up before? Do they have a neurological problem? They've got Charcot-Marie tooth, they've got semi-progressive, have they got MS? There's all these things that a foot pain can present with, or can present as a foot pain, as I said down there. And have they had a history of DVT or P, or that's probably slightly less relevant. And then look at your patient, and actually look at your patient as they walk into for you to examine them. Your first examination is as they come through the door, because they don't think you're watching them, and therefore that would be the most natural thing they will ever do in front of you. If you really can, watch them walk up the corridor to the examination room. That's the best one, because they genuinely don't think you're watching them, because everybody can put on a limp when they want to. So watch your patients, watch how they walk, look at the aids they're looking. Just look at the gait. Is it symmetrical? Is there a limp? Are they dragging their foot? Are they lifting their foot? You can tell all of these things in about 10 paces up the corridor. When they take their foot off, for you to have a look, just have a look at the sole of the shoe. It takes 5 seconds. You can see the wear pattern. Are they wearing the outside of the shoe, the inside of the shoe? Get them to take their socks and shoes off, and then get them to stand up to start with. You know, you can see on the slide here, have they got the heels? That's the too many toes sign, where the forefoot's externally rotated because they've got a sort of flexible flat foot or a cave of various foot. You're looking at all of these things. You know, what does the arch look like? What does the shape of the foot look like? What does the skin look like? What does the colour look like? Look at the foot standing up, because quite often I will see a foot that looks normal when the patient is lying down on a couch. And you stand them up, and suddenly the arch collapses and the foot externally rotates. You won't see that with them lying down, so you have to look at them standing up. Look at them from the front, get them to turn around, looking at the back. That does two things. A, you can look at the heel from the back, but also you can see how they're actually moving. Because if you ask them to do something suddenly, they won't have to think about it, and therefore you're going to get a more natural reaction to what they're doing than somebody who's trying to either compensate for it or milk it. And that's what I said beforehand. The site of the pain is important. You know, hallux valgus will usually be painful laterally, so will gout. Hallux rigidus is usually painful dorsally. And we were talking yesterday about this, about Morton's neuromas, which I'll come on to in a minute. Morton's neuroma will be painful between the metatarsal heads, but you sometimes see patients that have pain on the metatarsal heads. If you feel it on your own hand, you're less than a centimetre's difference between the two spots. It's not a lot, but it's really important. The site of the pain will give you the diagnosis. You know, so one of the girls I was talking to in the group yesterday did a lot of scans of feet, referred for Morton's neuromas, and they're all normal. She said, well, how many neuromas do you see on a scan? And I said, well, on an ultrasound, probably apart from 2, maybe 3 patients in 20 years, they've all had a positive scan. But it's about picking your patients. And if you've got painful metatarsal head, it's unlikely to be a Morton's neuroma. It's pain between the metatarsal heads. And if it's painful all over, you go, right, where's the most pain? You know, is it number 1, metatarsal head, number 2, between them? So I might come on, I'll talk about it now. I'll skip through the slides when we come to them. But with the Morton's neuroma, and we'll talk about Mulder's click and everything else in a minute. So I'll talk about that in a minute. But a Mulder's click, I think, I very rarely find it, to be brutally honest. I don't really see a Mulder's click. Quite often they're painful if you squeeze the forefoot, so the 5th metatarsal head and the big toe. Squeeze them together, they often get pain. Probably 50% of them get pain into the toe, and less than that get pins and needles. So the classic description of a Morton's neuroma, I don't usually see it. It's usually pain between the toes, sometimes with pins and needles, usually with a painful squeeze and a positive ultrasound. So it's having that clinical suspicion. Knowing what the normal range of movement is pretty reasonable. So an ankle should move fairly well. Subtalar movements should be free, but you only get about 5 or 10 degrees varus of valgus at the subtalar joint normally. Compare the sides. All right, I can't emphasize that enough. Most patients have a normal side for them. Might not be normal, but it might be normal for them, and they've got an abnormal side, and you've just got to find what is not. Because if they're both the same, then it's probably not an instability, and that's not the issue, it's something else. There's probably 4 tendons you really need to assess. I mean, yes, you can assess the HL and the digitorum, but fundamentally it's the tib post, tib ant, perineals, and the tendo Achilles are probably the 4 that are most important when you're walking. It's very easy to examine the tibialis anterior. It's basically foot at 90 degrees and then just get them to push immediately against the finger. Very simple. Perineals the same, but laterally. Tibialis posterior is slightly more difficult. So I think in this picture he's got his fingers there. I would suggest you put your fingers here. So what you're doing is you're probably pressing up at about 45 degrees and back at 45 degrees. You get them to dorsiflex, plantar flex the foot, internally rotate it, and then you're pressing up that way. And what you're looking to see is that tib ant isn't contracting, and you can see tib ant contracting. If you can't see it, you can always palpate it. So some patients with a tib post insufficiency will compensate by using tib ant, but in order to do that, they have to dorsiflex the foot, and then they can compensate. So long as the foot's plantar flexed, internally rotated, press up and get them to prevent you from pressing up. And if they've got medial pain and you're testing tib post, you can then run your finger behind the medial malleolus and up the tendon. If it's tender, they've got tib post problems. It's a very simple thing to do and very quick, and will give you a diagnosis. Right, this is the slide I keep telling people to forget. So this is the cutaneous sensation in the foot. I can't remember it, to be brutally honest. It's probably more relevant if you're doing diabetes and if you think there's a neurological problem. Occasionally with medial tarsal tunnel syndrome. So sometimes patients with a neurovascular bundle that comes behind the medial malleolus, they can get a bit like carpal tunnel syndrome, but it's a tarsal tunnel around there. But they've usually got local symptoms, so they might complain of numbness in the heel, but they'll also have a positive Tinel, so when you tap over the nerve, they get pins and needles and tingling and pain in the tarsal tunnel just below the medial malleolus. So you're looking sort of in this region around here. So it's useful to try and remember that, but it only tells you which nerve might be irritated, but it doesn't tell you where. So it doesn't tell you where if it's irritated in the foot or in the hip or in the back, to be honest. We've gone through this a little bit, so that's alignment, looking from the back. So the cava varus foot, for instance, like this is called the Coleman block test. So is that deformity driven by the heel or is it driven by the forefoot? So you get them to stand on a block, drop the big toe down, you find that the heel corrects and therefore it's a forefoot problem, midfoot problem rather than the hindfoot problem. If it doesn't correct, it's a hindfoot problem. So it really tells you where the problem is or how you're going to treat it. And I think that's quite important because you can treat a forefoot much differently from a hindfoot. Ruptured Achilles tendon, Simmons test. You can either do it with them lying down or you can do them with them kneeling down. I usually do it with them kneeling in the clinic, we do it lying. I think the two things are, number one is the attitude of the foot. So if you ever get to see somebody kneeling with their feet over the end of a bed, the foot doesn't sit at 90 degrees because there's some tension in the Achilles tendon. It will sit at about 70 degrees. That's normal. If it drops to 90 degrees, they've got an Achilles tendon rupture. You can see that here. So there's normally a little bit of an angle, and there's no angle on that foot at all. Simmons test, you squeeze the calf, the ankle shouldn't plantar flex. Now occasionally you get a false positive. So very occasionally patients have got a tendon called the plantaris in the heel, which works, and that can cause a positive Simmons test. And just occasionally they're not relaxing. Sometimes with a partial tear it's positive as well. It doesn't preclude an injury if it's negative. So if it moves, it's negative. If it doesn't move, it's positive. If it doesn't move, it's positive. If it's negative, it doesn't necessarily mean they haven't got an injury. It means they've probably still got a functioning tendon at the moment. So the Silver Skulls test, which I've been doing for many years and forgetting what the name was, but fundamentally you're trying to see if it's the gastrocnemius or the whole of the complex calf muscle that are tight. Gastroc is inserted above the knee. So if gastroc alone is tight, you'll have some tightness of dorsiflexion. You bend the knee, you take the stretch off the gastroc, they can dorsiflex further. They can't dorsiflex further than the gastroc and the soleus are both tight. Might make a difference, I would have thought, to your physiotherapy. It certainly can make a difference to the surgery you give somebody. So if it's just a tight gastroc, you just release the gastroc. If it's tight gastroc and soleus, you sometimes have to do a tendon lengthening rather than merely a gastroc release. So that's the anterior draw. Again, we talked about that earlier on. As I say, the other one to do is actually directly stressing the tibialis, sorry, the ATFL. Finger over the fibular head, finger over the talar head, and see how much they move and whether there's a firm end point or not. And I think it's the firm end point. And again, compare the sides. Grind tests, don't like, but it's described in the books. Mulder's click, we've talked about that. I don't know what anybody else's experience of a Mulder's click, but as I say, I very rarely see it personally. It's nice when you do see it. Not nice for the patients because they usually go ouch, but...
So you're saying then that if you don't get the click, it doesn't mean it's not a neuroma?
Most of the patients who have a neuroma do not have a Mulder's click in my experience. Probably a lot, maybe 50% don't have the standard pins and needles down into the toes. It's pain between the metatarsal heads, particularly if you squeeze. So if you get a finger here and a finger there and squeeze the toe box, and that causes pain, that's fairly significant. So it's site of, in my hands, it's site of pain and an ultrasound. I've probably twice explored somebody's foot with a negative ultrasound, just because I think they probably did have pins and needles and tingling, and it wasn't on the ultrasound. So I said, well, I'll have a look, but I can't guarantee it. And they were fully informed and they were happy with that. But on the whole, ultrasound positive. But yeah, Mulder's click is not much less common than you read about, I think. So I think there's 4 things you can probably inject quite easily in primary care, and in, I'm not sure about Morton's neuromas. That was the one I would query. Okay, I'll go into that in a minute. And yeah, if you use adrenaline, you tend to make things die, particularly around toes. So you've seen this slide before. The important bit is you go just medial to extensor hallucis longus. Your dorsal digital nerve is running here. So if you look on the big toe, you've got your extensor hallucis longus here. Your dorsal digital nerve probably runs in this corner here. So there's a little gap, nice big 1 centimetre gap you can stick your needle in. And remember that the joint is a cup. So you have to come in like that and probably like that. So it's about 40 degrees and 40 degrees. You're trying to get under that lip of the base of the proximal phalanx. If you go straight in, you're either going to hit the cartilage, the metatarsal, and you're not going to get in properly. And just remember, you can only get about 2 mils in here if you're lucky. So when you're doing injection, always put a little bit of local in first to make sure you're in the joint. But don't put more than half a mil into this joint. If you stick 1.5 mils in, you're not going to get that 1 mil of 40 milligrams of depomedrone in it, or Kenalog, whatever you're using. So you can only get a small volume in the first metatarsal. The reason, I mean, a lot of my colleagues will inject around Morton's neuromas. I think 90% of them, the symptoms will come back in a year, personally, because actually you're not dealing with the problem. Once you have a neuroma and you've got damage, it's scarring within the nerve. So if you've got a nerve that's irritated but not scarred, injecting around it might settle it down. But you've got to ask the question, why is it scarred? So what's the cause of the Morton's neuroma? So actually, you're probably just as well treating these before you think about injections with metatarsal bars and orthotics, just to try and spread the metatarsal heads and stop that compression of the nerve. The other difficulty with injecting the nerve, you can sometimes inject into the nerve. And I've had at least 2 patients that I've seen over the years who've had injections into the nerve who come back with CRPS, intractable pain, and that's despite taking the nerve out. So if you're going to do it, I would suggest you use ultrasound guided around the Morton's neuroma just to avoid injecting into the nerve. And it's a fairly easy technique to learn. Ankle injections, we've talked about this. So that's your tibialis anterior. It's next to the one that works your big toe. That's the medial malleolus, and there's a hole there. You can sink your finger in. That's where you inject. That's the safest place because you've got your extensor digitorum. Actually, it's over here, not over there. And that's where your neurovascular bundle is. So always be medial to tib ant, and you will never ever be in the neurovascular bundle. It's also less pain for the patient if you don't go through a tendon, to be honest. And again, come distal a little bit and then go uphill. Because again, you've got to remember it's a dome joint. Okay, if you go straight in, you're going to hit the talus. So you've got to come down a bit and go up, and you can always feel, if you can get the whole barrel of a blue needle or a green needle, and you know you're in the ankle joint. Because it's quite superficial normally. Plantar fascia injections are quite interesting. It sort of seems to go in vogues and waves. This is sort of describes where medial tuberosity is and where it's usually painful. What my suggestion would be, if they've got plantar fasciitis, and you stick one finger on the sore spot, which is usually there, so it's usually on the medial tuberosity, it's probably worth injecting them. They still need physiotherapy, still need all the other treatments, but a single sore spot you can inject. If it's diffuse, where are you injecting? So I wouldn't ever inject somebody who's got a diffuse pain. And if you've got pain here around the heel, please never inject them. All that's going to happen is they're going to get fat pad necrosis, and you're going to make the symptoms worse. So there's various ways of doing it. You can go in through the side if you want. You can come in through the sole of the foot if you want. It doesn't matter as long as you're injecting onto the sore spot. And again, 1 mil of local, 1 mil of depamedrone. Warn them it's going to hurt because you're injecting into and around the fascia. So it's not distensible. It doesn't move out of the way when you inject it. So it is going to hurt. But if you pick your patients right, you pick the ones with a single sore spot, it seems to work quite well. But they do come back, and you do see them coming back, and that's because they never got any physiotherapy afterwards. So the injection facilitates the therapy. Any questions? Comments?